بسم الله الرحمن الرحيم. السلام عليكم. أنا دكتور حمدي حسونه، أخصائي أمراض روماتيزمية. أنا نبي نفحص إيديك عشان نشوف إذا كان أي مشكلة مرضية في إيديك. شنو اسمك الكريم؟ تسمح لنا أن نبدأ الفحص؟ أوكي، شكرا، بارك الله فيك. Okay, first starting the examination by inspection. Should inspect the hands. Very important part of the inspection is to inspect, looking number one, going from distally and go to proximal area. Distally, you look for the nails. You should examine the nails. Okay, look for the nails. There is no nail bitting. There is no onycholysis. Okay, there is no red spot suggestive of vasculitis or suggesting of splinter hemorrhages. So nails are free. Hand down. Okay. Second point, looking for evidence of any wasting. Here you see the bulk of the muscle. You look into the dorsum of the hand. The bulk of the muscle, they are so prominent. There is no flatness. There is no muscle wasting. Second, I'm looking to the knuckles of the hand. This is the knuckle. There is no skin rash. Over this area, there is no skin rash. Here, there is a psoriatic patches, or there is a Gotron sign suggests dermatomyositis. In this patient, is clear. There is no Gotron. There is no psoriatic patches by the inspection. Number three, here, there is no scar. No evidence, no any scar on the dorsum of the hand. There is no clear scars suggestive any underlying operation has been done. The hand, they are in neutral position. There is no clear deformity. As we see here, there is neutral position of the metacarpophalangeal joint. There is no ulnar deviation. There is no radial deviation. There is no obvious deformity seen. At the wrist joint, there is no deformity. At the metacarpophalangeal joint, there is no deformity. At the proximal and distal, there is no deformity. No deformity suggestive of the swan neck. If we have swan neck, usually we have an hyperextension, and there is an flexion at this phalange, proximal and distal. Hyperextension, and there is a flexion at the hand. There is no obvious deformity have been seen into the hands. No muscle wasting, no scars, no deformities has been seen. Second, we are going to palpate. Palpation, we have 2T. Number one, looking for evidence of any raised temperature. There is no warmth, just examining the patient by applying our dorsum of the hands over all the joint areas, all over the joint areas. So temperature looks normal, there is no warmth of the hands. Then we are going to examine for the tenderness, looking for the tenderness. First, we start with the wrist joint. We are applying the index and thumb finger here at the carboradial and the carboulnar and breast. We are looking to the face of the patient. There is no area of the tenderness. Going from lateral, going towards the middle of the hand. So the carboradial, carboulnar, pressed by thumb and index finger, and breast looking to the face, there is no tenderness. Then you go to the second hand to compare two joints at the same time. Press up and down, looking to the face of the patient. There is no tenderness, there is no tenderness. Then by pressing to the lateral part of the wrist joint, lateral part, by using of the two index fingers, and there is no area of tenderness. Here there is no area of tenderness. Second joint, are looking for the metacarpophalangeal joint. Metacarpophalangeal joint, MCBs or metacarpophalangeal joint. This is by pressing by the index and the thumb. From up and down, are looking to the face of the patient. There is no tenderness. Then by pressing anterior and posterior, there is no tenderness. Anterior posterior, there is no tenderness. And here by using the right hand, thumb and index finger, there is no tenderness. By looking to the face of the patient, then looking to the lateral part of the MCBs. Here, there is no tenderness. At the same time, laterally, there is no tenderness. Then the press over the metacarpophalangeal joint, up and down, anterior, posterior, there is no tenderness. Every time you are looking to the face of the patients, okay? Then you are going to the proximal interphalangeal joint. This is proximal interphalangeal joint. Proximal interphalangeal joint. By pressing proximal interphalangeal joint, we have two parts of the joint, anterior posterior part, and we have a lateral part of the joint. So we press up and down, this anterior posterior, looking to the face of the patient for any tenderness. Then pressing laterally by two index fingers, there is no tenderness. By using the second one, there is no tenderness. Laterally, then anterior posterior, then you're going laterally, anterior posterior, and go laterally, there is no area of tenderness. Go to the distal, by examining distally, anterior posterior, there is no tenderness. Laterally, there is no tenderness. Here, laterally, there is no tenderness. Anterior posterior, there is no tenderness. And this little finger, anterior posterior, and go laterally, there is no tenderness. Apply to the same hand, same maneuver to the second hand, anterior posterior, anterior posterior, anterior posterior, tenderness, anterior posterior. Every time look into the face of the patient laterally, then laterally, thumb and index, you go laterally, thumb and index laterally, and look into the face, anterior and posterior, anterior and posterior. Then you go last thing, thumb usually examined alone. So examine the thumb, anterior posterior, for any tenderness, and then you go laterally. The proximal part, see here, metacarpophalangeal joint, and applies laterally and anterior posterior. The same here, anterior posterior, and apply laterally for the tenderness, and then you do it the same joint, anterior posterior and laterally. Here we are finishing examination for the temperature and tenderness, which is very important part of the examination. Then you go to assess the movement. Number one, the most important movement to assess the flexors of the hand. We have flexor of the wrist, we have flexor of the metacarpophalangeal joint, proximal phalangeal and distal. Do fist, sacroiliac, okay? Now we are going to assess the power. Patient able to close the hand, then assist the wrist joint. A wrist joint, there is a flexion, there is extension, there is an abduction, and there is adduction, okay? Just ارفع يده فوق, okay? نزل لوطة جوا برا. So the wrist joint is okay. Here ارفع يده فوق, the extensor they are powerful. Now apply your hand to the joint line, this joint line, نزل يدك لوطة. It's okay, flexor is okay. Then abductors برا, adductors جوا. So this four movement at the wrist joint. Flexion like this, extension, abduction, and adduction. We finish with the wrist joint. We are going to examine each اللي هو metacarpophalangeal, proximal and distal. They examined all together. Okay, سكر ايديك. So patient able to close the hands, able to close the hand. So flexors, power at the metacarpophalangeal joint, at the proximal and distal, they are intact. Okay, there is no deformity. If there is any deformity, the hands will be open like this. Okay, at the distal, the hands will be like this. At the proximal, more open. At the flexor, the hands unable to close at all. This position indicates that the patient has weakness of the flexor muscle of the metacarpophalangeal joint, and he has a weakness of the proximal and weakness of the distal interphalangeal joint flexors. Very important part to examine for the flexors. Okay, the other point of the examination, ask the patient to do fanning. افتح ايديك. This is هذا test for lumbricals, what's called lumbricals. Lumbricals are responsible for the abduction and the adduction. Okay, ask the patient now is close the hands, سكر ايديك, افتح توا, assessing the power, he is unable to open the hands. Okay, سكر افتح. So the abductors, they are okay. Okay, we need a paper now. We have a plain paper to be used for adduction, any paper. Okay, put the hand down here. Okay, so our examination to test the power of the adductors and abductors. Just compare two hands, right hand with my right hand with his right hand, the same power. Here we're applying the index and middle finger. Okay, like this. I try to get out the paper out of him. Okay, I am unable to put it out. So this is the adductors. They are normal in strength, normal to the power. Then apply second group of the muscle between the ring finger, between the second finger and the middle finger. Okay, خلينا نسحبها. So here there is some weakness into the muscles. Okay, apply other group here, and this is adductor muscles. Okay, and able to do it. Okay, here is intact. Do it with the left hand the same. Apply the same group of the muscle, left hand for the left hand. Don't use the left hand to examine the right hand. Same group of the muscle, the index and the middle finger. See here. So muscle is intact. Then test the other group of adductors. Okay, down, your hand down. Okay, here there is some weakness into the muscle of adductors between the middle and second finger. Apply to the small group of muscles, little finger. Okay, so the power is intact. So we test the adductors and the abductors. We had test the flexors. Now we are going to test the power of the flexors and extensor of the wrist joint. سكر ايديك هنا. Okay, just extend. Okay, لوضة. Okay, it's okay. So muscle power is intact at the wrist joint, at the metacarpophalangeal joint, and at the lumbrical level. Okay. Then we are going to examine the palm. Don't forget to examine the palm finger. First, examination of the palm is a very important part of the rheumatoid hand examination. First, looking by the inspection. First thing, look for the thinner and hypothinner muscle wasting. If there is any wasting here, the bulk of muscle is normal. If there is any wasting, you see there is a flatness of the muscle here. There is a flat, or more severe wasting, there is each depressed area at this site. Okay, so here the thinner and hypothinner muscle, there is no muscle wasting. At the same time, by examining the thinner and hypothinner, looking for evidence of presence of palmar erythema. There is a presence of any redness at this area, the thinner and hypothinner area, which suggests the patient has palmar erythema. If there is a palmar erythema, suggests that the patient has an active disease. Second, you're looking for evidence of any skin rash. Common skin rash into the palm, the presence of digital vasculitis. Rheumatoid vasculitis, they are red spot at the terminal phalange. You see here, look for evidence of any red spot, painful red spot. While you are breathing into the spot, the patient will have a severe tenderness. Presence of red spot at the terminal phalanges is suggestive that the patient has rheumatoid vasculitis. The other point into the examination, you see here there is a wrinkling along the fascia. This is the fascia. Okay, this is what's called the fascia. Let's call this fascia. This fascia, there is an inflammation like in Dupuytren contracture. Dupuytren contracture can be seen in rheumatoid arthritis, can be seen in diabetes. So the patient will have a flexion of all the fingers at this area. There is a swelling, prominent swelling, and there is an affliction at this area with so-called Dupuytren contracture. Dupuytren contracture. Okay, at this area you may look for evidence of any subcutaneous nodule. Subcutaneous nodule usually present over the knuckles. Can be in the palmar aspect, you see subcutaneous nodule at this area, at the knuckles, or commonly onto the dorsum of the head. Presence of the subcutaneous nodule, there is a prominent nodules are present along the knuckle. This is the knuckles. A presence of any prominence, subcutaneous nodule, usually they are freely mobile. You apply your hand, you feel that something is moving beneath your hand. Freely mobile movement of nodules beneath the knuckles suggests that the patient may have a prominent subcutaneous nodules. So this is commonly how to examine the hands. Second stage, you are looking for evidence of any neurological issue, any neurological compression. The commonest neurological abnormality in rheumatoid hand is the presence of carpal tunnel syndrome. As we know that the median nerve is passing through the flexor reticulum at this area, passing of the medial nerve. Compression of the median nerve leading to feeling of paresthesia and numbness along the medial 3.5 finger. 1, 2, 3.5. All this area the patient will have a tingling sensation, paresthesia and numbness. This is medial 3.5 finger, suggests there is a median nerve compression. How we examine for that? We are looking to have two signs. First sign was so-called the Fallon sign. لصقنا بعضنا هنا من فوق. اوكي تو سكر النك بقوه، سكر بقوه. في تنميل في ايديك ولا لا؟ فيش اي تنميل في الاطراف. اوكي. If there is a paresthesia, numbness along the medial 3.5 finger or pain at the forearm, if you feel paresthesia, ما فيش ألم هنا. Okay, if there is no pain at the forearm, there is no paresthesia. And numbness at the medial 3.5 finger, patient has Fallon sign is negative. The second sign, maybe Fallon sign is negative, but Tinner sign may be positive. Tinner sign indication what? As we know that median nerve passing through a flexor reticulum, we need to percuss over the area. This is the joint line. If you see here, this is the joint line. Just proximal to the joint line, you need to percuss by using two fingers. Just percuss here. فيش تنميل في ايديك. اوكي ما يحرقنش فيك. فيش ألم. فيش ألم فوق هنا. صوت. Okay. Do the second hand here. Go from the medially lateral to medial, go from the medial side and percuss over to the lateral side. مفيش تنميل مفيش ألم. So here tenal sign is negative and Fallon sign is negative. Okay, so this is by at the end of the examination, they will ask you about your differential diagnosis. Usually, common deformities into the hand are due to common diseases. Two common diseases are the rheumatoid arthritis. The second is the psoriatic arthropathy. Psoriatic arthropathy and rheumatoid arthritis, they are giving the same picture. The differentiating point into the examination, we are going to finish by the examination of the nails. Examination, presence of nail bitting, presence of unequal lysis, lysis of the, you see that the nails are going up from this side to unequal lysis. Presence of nail bitting are suggestive that the patient has a psoriatic arthropathy, important differentiating point. The presence of psoriatic patches over the knuckle, whitish spots, presence of white plaque with white spot over the knuckle of the hand are suggestive of psoriatic arthritis. The differentiating point, presence of psoriatic patches, presence of nail bitting, presence of what? Of unequal lysis. The other point in differentiating rheumatoid arthritis from the psoriatic arthropathy or distal interphalangeal involvement. If the patient has any painful tenderness or swelling in the distal interphalangeal joint, this is strongly against rheumatoid arthritis. Rheumatoid arthritis doesn't involve the distal interphalangeal joint. If there is a distal interphalangeal joint, meaning that the patient most likely has a psoriatic arthropathy, no rheumatoid arthritis. Okay, by this examination, we had finished the examination of the rheumatoid hands. Shukran. Thanks.